Hi there everyone, Richard Armour here, interim paramedic practice leader with the last monthly update from the clinical and professional practice team for the year 2021. Goes without saying, but I'm going to say it anyway. We want to take a moment before starting this video on behalf of the team just to thank every paramedic, EMR, first responder, anyone involved with out-of-hospital medical care in the year 2021 for your continued resiliency in the face of seemingly insurmountable challenges between heat dome, the flooding, the ongoing pandemic, and the opioid crisis. Your ability to provide high-quality patient care despite all of these challenges doesn't go unnoticed, and we really thank you for your commitment this year and look forward to working with you again next year. So some of the pieces that make up the contents of the last monthly update include a new CPG for patients with epistaxis. We've got two new assess, see, treat, and refer pathways, one for epistaxis and one for asymptomatic hypertension. The Abbotsford Urgent Primary Care Centre is now accepting patients from secondary triage and patients with minor wounds, minor allergy, and minor burns. And a couple of practice reminders that I just wanted to highlight here in the video around the use of the Insight app for American Sign Language interpretive services, as well as some guidance from paramedic practice leader John Deacon around primary care paramedic use of the Lifepak 15s. So Astar Epistaxis, it's our first pediatric assess, see, treat, and refer. It includes patients aged 2 years or greater, and patients are eligible if they have an episode of epistaxis which has resolved after 15 minutes of direct compression, whether that's from yourselves responding on scene or whether that's following the patient's first aid instructions from our emergency medical call takers. For adults, we need the patient to have a NEWS2 of less than or equal to 4 and no single score of 3. And for pediatrics, we're looking for patients with no vital signs outside the normal limits. There's a couple of specific exclusion criteria that I just want to quickly highlight from the pathway, which are specific to Astar Epistaxis. It includes patients on oral antiplatelet and anticoagulant therapies, as these patients need some testing to monitor their levels of antiplatelet or anticoagulant therapies and are at a higher risk of rebleeding. Patients with known or suspected coagulopathies, so inherited coagulopathies or severe liver disease, for example, these are explained in the CpG E11 epistaxis. Foreign bodies remaining within the nose as a cause of the epistaxis, and non-accidental causes of epistaxis. So we ask you as paramedics to continue to be vigilant and aware of the possibility of child, domestic, or elder abuse as a potential cause of the epistaxis. For enrollment in Astar Epistaxis, there is a required clinic call to the paramedic specialist to discuss the case, just to provide some real-time clinical governance around the pathway. And then following that, the patient will receive a follow-up call in 24 to 48 hours from the PS team. And when you complete your care of the patient on scene, we'd like you to signpost the patient to their general practitioner, a walk-in clinic, or any primary care service within the community if there's a recurrence of the epistaxis which is easily managed, or if this is an ongoing issue for the patient. The second Astar pathway we've got this month is Astar asymptomatic hypertension, and this is for patients who are age 17 years or greater and contact emergency medical services because they've found on routine monitoring of their blood pressure that it is elevated. So we're continuing to work to build a system where these patients are identified and downstream to appropriate healthcare providers to manage the condition, but in the interim we wanted to create this guideline to empower paramedics to have informed conversations with patients around their options for care and the most appropriate setting for their care. So this is for patients aged 17 years or greater with a systolic blood pressure less than 180 and a diastolic blood pressure less than 110. The patient has to have a NEWS2 less than 4 with no single score of 3, otherwise asymptomatic, and access to any sort of primary care service within their community. It's important to note that postpartum patients are excluded in addition to pregnant patients, as well as patients with recent head trauma, sympathomimetic use, or other medical complaint. As with Astar Epistaxis, a mandatory clinical is required to enroll the patient in this clinical pathway. So I wanted to take a moment just to remind paramedics about the availability of video remote interpreters for deaf, deafblind, and hard of hearing patients. The interpreter app called Insight is installed on every BCEHS phone across the province, and there are interpreters available 24/7. There's just a short video here which I think highlights just how easy it is to use, and it is an expectation of clinical and professional practice that for patients who are deaf, deafblind, and hard of hearing, that this app is offered as a means of interpreting. The app itself really is as simple as it looks in the video. You simply open it and request to connect to an interpreter, and they're available 24/7. For this community, it's been incredibly difficult during the pandemic to lose the accessory ability to lip read, and it is just so crucial for effective patient communication and equitable patient care that we're employing the app wherever possible to support these patients. And then finally, just a note from paramedic practice leader John Deacon around the use of Lifepak 15s by primary care paramedics. So we've seen increasingly widespread deployment of Lifepak 15s around the province, and the rollout continues throughout the next months for LP15s, generally designated for interfacility transport work. However, we know that, of course, that many of these units will end up attending 911 events, and for that reason, John wanted me to pass on the message that it is acceptable for PCPs to use the LP15 according to the BCEHS Clinical Practice Guideline C01, Acute Coronary Syndrome. Specific for primary care paramedics, the paramedics using the LP15 must have received the online training, the face-to-face component of the training, and as well as the EMALB endorsement. And the LP15 can be used for patients over 18 years of age with active non-traumatic chest pain suspicious for acute coronary syndrome when the patient is en route to the hospital. So what to do, of course, with the monitor findings? For patients in regions with no established PCP STEMI clinical pathway, primary care paramedics should continue in their normal practice and notify the receiving hospital that they're en route with a potential STEMI patient. And if available, primary care paramedics should request advanced care paramedic support if they're available in their area. For paramedics working in regions with established primary care paramedic STEMI clinical pathways, then those primary care paramedics should follow that pathway for patients to be taken direct to percutaneous coronary intervention, including transmission of the ECG to the receiving hospital, a request for advanced care paramedic support if available, and hopefully conveyance within the 60-minute transport time window. So just some clarification there from John Deacon on the use of LP15s for primary care paramedics who primarily have it for interfacility transfers, but who are running into patients during their 911 calls with active chest pain. So that's our last update for this month, for this year rather. As always, any questions, please do not hesitate to reach out to clinicalpractice@bcehs.ca. We love hearing your questions. We love advocating for you as paramedics and professionals to find better ways to deliver patient care for paramedics in the out-of-hospital setting. We'll see you all next year.